Hello, hi to those who have just joined. We are reconnecting with Dr. Schmeichel, who is the medical director at Laurel Fertility Care, a boutique fertility clinic based in San Francisco Bay. And today we're going to be discussing everything to do with thyroid issues. He'll answer your questions live as it is Thyroid Awareness Month in the States. So thank you for everyone who sent your questions in advance. They're brilliant. And we're ready to answer them now. And if you have any questions you want to ask live, please do so. So he will be joining any second and then we can go live. Happy New Year to everyone who's joining. It's my first live since the new year. Hope you had a good one. Let's see, he should be here in a minute. Anyone who's joining, is thyroid something that you want, well, of course it will be, but want to know more about? What's been your experience with thyroid issues and fertility? What would you like to ask Dr. Schmeichel? And I'll make a note to ask him. Okay, yep, that's something we're definitely going to cover, so bear with us. He'll be here any minute. Let me just have a look. He's just logging into the Laurel account now. Someone said definitely, I get my meds dosage correct, definitely. Okay, let's see. Hello, hi to those who are joining. Thank you so much for your questions. Shall we answer all of them? Give us a sec. There we are, great.
Much better. Thank you so much.
No worries. I've just introduced the subject for today. Please could you introduce yourself? And then we've got some brilliant questions which have come in around thyroids and fertility.
Okay. My name is Dr. Colin Schmeichel. I am the medical director at Laurel Fertility Care in San Francisco. We have offices in the Bay Area at Fresno and opening a new office in Oakland soon.
Exciting. Great, thank you. So it's Thyroid Awareness Month, isn't it, in the States? And one of the main questions that came through was, please could you explain a bit more about an overactive thyroid and also an underactive thyroid and what the causes of that might be?
All right, so let's first look, and the thyroid gland is a gland that's in the neck that basically produces the hormone thyroxine. That's basically a hormone that's used a lot in metabolism. And a overactive thyroid may be where the thyroid gland starts making too much thyroxine, and underactive thyroid means you're not making enough. How we measure and how we monitor that is we can measure thyroxine directly, but we measure what we call the thyroid stimulating hormone. That's a hormone that's made by the brain to kind of stimulate the pituitary gland. I'm sorry, from the pituitary gland into the thyroid. And that's how we'll actually measure and see how active the thyroid is. And so someone who has...
Sorry to interrupt you, but when people see things that they need to be tested for, that might say TSH, is that right? It's
correct.
A shorthand.
The TSH is the hormone that we measure. That's the one that we can kind of reflect to see what's going on. So someone who has a hyperactive, meaning there's too much TSH, that means that you'll end up having a thyroid gland that's really overactive. And so underactive, because the thyroid gland is being stimulated by the TSH, and that means you're not making enough thyroxine. Mm-hmm. Whereas an overactive thyroid gland may make the TSH really low. Okay. And that's another thing that's measured.
And what are the causes of it? Is it something that's hereditary? Does it just develop? What happens?
So there are some parts that can be hereditary. One thing that people may hear about is Graves' disease. That's where you end up having what they may call a hyperactive thyroid gland. Your body starts making some sort of antibodies against the thyroid gland, so therefore it produces a lot of the thyroid hormone. And so therefore it'll actually lower the TSH level. And so therefore you'll just have a lot more thyroxine produced. That one of the things that people will feel if they have too much is you'll find somebody who actually has a lot of energy. They feel really bouncy. They feel like, their heart's racing. So that's something that will actually feel if it's too active. If it's really, really high, then you may end up starting feeling weak or tired because of, your body just being exhausted. So
Mm-hmm.
that's something that's actually seen.
We've just had a question come in which is relevant for this right now.
Mhm.
What is the optimal TSH level for fertility?
Very good question, because we look at thyroid. If you're in the general population, you may end up having thyroid hormone levels of 3 or 3.5 being in the normal range. Whereas if you're trying to get pregnant, or you're basically looking at managing, thyroid hormone during pregnancy, you want a level that's going to be between 1 and 2.4. If it's low, that means you may end up having too high active thyroid gland, and that's something that we have to be concerned about. And if it's too high, that means you have too low effective on the thyroid gland. Both affects the fetus while it's developing, and both need to be managed because both have consequences in terms of the pregnancy. If it's too low, you can end up having miscarriages, and that's one of the things that can actually happen. If it's too high, then, and especially as you go further along in pregnancy, the thyroid hormone can pass through the placenta and affect the fetus, and therefore the fetus becomes hypothyroid.
And what does that mean exactly?
So that means that the fetus may end up having what we call a goiter, where basically you'll end up having an enlargement in the fetal thyroid gland in utero. And
Right.
then that means after birth, the fetus may end up having a lot of consequences or symptoms you have to manage. So that's something to try to avoid.
Okay. So, how do people, if people are being tested for a thyroid issue and it comes out that they do have an underactive or overactive thyroid, what are the best treatment options, both with Western medicine and also what people can do perhaps naturally to help their thyroid?
So if you're the so from a dietary standpoint, one thing to know is just that there are things that are you're taking in naturally that'll affect the thyroid gland. Um, Iodine or any of the iodinized compounds may actually, it helps to support the thyroid. So we know that earlier on, before you didn't have iodized salt, that you end up having a lot more patients who had thyroid symptoms. Most salts today have iodine in it, so therefore it's something that it manages the thyroid gland for most patients. But there are some who, if you're hyperthyroid, that means you're going to end up having too much stimulation of the thyroid gland, and therefore you want to try to avoid any iodized salt. You're also going to try to avoid any shellfish because that actually also concentrates iodine. And so basically, shell, seafood type complements. So like many type of seafood or kelp or sushi, those things are things to avoid as well. Iodine supplements are another things to avoid. So therefore, that's something you have to kind of recognize. On the other hand, if you have hypothyroidism, you're going to need some more of those supplements. So therefore, you are going to then look towards eating the exact opposite of those things in terms of eating more, putting more iodized salt in your diet, adding more fish, adding more things that's going to basically help to support that type of environment.
Do you see patients help their thyroid through diet and supplements alone?
Yes, they can in terms of managing some symptoms if it's basically what we call borderline, meaning it's not too high. Whereas, if someone who's hypothyroid, they can actually start eating these compounds and then that'll help. If it's too high where, you're having thyroid levels that are over 5, TSH levels over 5, it's not likely that diet's going to be sufficient to manage that part of it. So you'll need to take medicines to kind of help to support that. A challenging one would be someone who actually has both a hypo and a hyperactive thyroid. And that's basically really hard to kind of explain, but it's someone who your thyroid hormones going through, or your thyroid gland is going through, for lack of a better term, some turmoil where if it's really, really sensitive to how much thyroid is around. Too much will cause it to be really hypothyroid and not produce enough. Too little will end up making it really try to respond overly. So therefore, in those patients, you'll have to really titrate how much thyroid they're going to be taking. Synthroid they're going to be taking, or some sort of levothyroxine they're going to be taking. And then sometimes patients will need to take a combination of both what we call T3 or thyroxine and hypothyroxine to kind of manage those symptoms as well.
Okay. And what percentage, I know it's impossible to say a percentage, so maybe
Mm-hmm.
that's one question, but how many patients do you see who have a thyroid problem? Is it a common issue?
It's becoming a common issue because we realize that basically there's a lot of patients walking around with a thyroid hormone level, TSH level of 2.5 to 3, and over the last, say, 5 or 6 years, we noticed that you'd actually have a higher risk of miscarriages in some of those patients who are in that higher range. So the American College of Gynecologists and several of our organizations then came about and started managing things a lot more actively. And then there are some investigations that showed that if you end up having a thyroid hormone between 1 and 2.4, the risk of miscarriage diminishes. So that's the range that we try to basically keep patients while they're pregnant or during the time they're trying to get pregnant. So that's that sweet spot we're looking for during that management time.
And before we answer some questions that have come in, what about if someone
Mm-hmm.
doesn't have a thyroid? Is that possible?
It can be basically someone who has a goiter, meaning basically there's an overall growth in the thyroid. They may end up having to have the thyroid gland being removed. And that patient can be replaced with Synthroid artificially. So therefore, that's an easy way to manage it. Another patient will actually have a thyroid tumor. So therefore, it's a cancer or precancerous lesion within the thyroid that may actually cause the thyroid to be removed. And those patients are also going to need to have supplemental thyroid hormone. So those are easily managed because there's nothing to kind of counteract what's being administered. So you just need to basically support that.
And if someone discovers that they have an issue with their thyroid, whether they're trying to conceive or not, does this automatically mean it's going to impact their fertility?
It's something that we look at a lot more closely now because we recognize that if someone's trying, we need to kind of manage that. I think it's something that we weren't paying as close attention to in the past. So therefore, patients used to get pregnant and miscarry, and we just didn't know. Now that we recognize that there's that sweet level, it is something that's monitored during your pregnancy. If you're not trying to get pregnant and it's not part of your well-being, then you may end up having other symptoms that you may need to have your thyroid addressed and managed, but not related to fertility. So if someone who is having challenges with losing weight or losing weight too quickly, those are patients may end up having thyroid issues that need to be managed, not related to fertility.
And how often should someone check their thyroid?
Hypothyroidism is more common in women. It also occurs in men, but it's something that you do need to kind of manage. It also increases as you get older. So, during, I'd say, the reproductive years, and that's a range that broadens as we go along. I would say checking your thyroid every year or every 2 years is going to be important. If someone does have thyroid disease, they're going to need to be checked more frequently to make sure that it's staying in a consistent range.
And I presume that would be throughout a pregnancy as well.
Definitely throughout the pregnancy. The other thing to realize is just that the placenta also makes a thyroid-like hormone that basically stimulates the thyroid. So that's another main way that they end up having either hypo or hyperactive thyroid. So during pregnancy, definitely you'll actually have it managed.
Okay, thank you so much. What about managing medication and prepping for fertility treatment? How does this whole thing come into that in terms of medication and what you need to take?
Well, if one of the things that we do in terms of trying to evaluate patients, one of the first hormones we look at is thyroid hormone. So if someone is beginning the process for evaluation for fertility treatment, the first thing we'll do is to check a thyroid hormone. And if we identify that the level is either too low or too high, we'll need to basically bring it back into the normal range before beginning treatment.
Yeah.
The reason for do that is just that we just don't want them to basically get pregnant, have this thing continue, and then have them miscarry. especially if you're going through a lot of the, the emotional and the financial drain of going through fertility treatment. We want to ensure that you'll actually have the maximal chance for success.
Mm-hmm. Okay, brilliant, thank you. And you mentioned miscarriage, which is obviously a huge thing for so many people experiencing.
Mm-hmm.
Someone has just said, is it normal to get your thyroid checked for recurrent miscarriage tests? Is that on the testing panel?
That is definitely part of the testing panel.
Yeah.
The secondary part of that same question is just that we know that hypo or hyperthyroidism may cause, may be associated with miscarriages. There are also some autoimmune, immunologic issues related to miscarriages, and someone may end up having what we call anti-thyroid hormones or anti-thyroid antibodies. Those really, really high levels may also impact miscarriage rates. Low levels of anti-thyroid antibodies are not going to be affecting the risk of miscarriages. So anything that basically causes some sort of hyper response in the immune system may be associated with the higher miscarriage rates.
Okay. In terms of treatment, is there anything more that someone can do other than being on Synthroid? Is that how you say it?
Synthroid. Mm-hmm.
Synthroid, that's
Synthroid.
it. Yeah.
Mm-hmm.
Okay. What can people do apart from that?
In terms of managing the thyroid hormone,
Yeah.
there are different. So being on some sort of medication to manage thyroid, it's easier if you're hypothyroid to manage those symptoms because you can always be on Synthroid or levothyroxine or some other hormone. The harder part is if you have a hyperactive thyroid, because what you will need to do is to then really suppress the thyroid, and you'll need to suppress it for a long period of time. So let's presume that someone actually has a thyroid hormone that is, really low, so it's less than 0.1, and they're starting to actually have heartbeat issues where they have irregular heartbeat. You may end up having those patients who looks like, they have, the eyes starting to bulge because they actually have hyperactivity from that. Those patients need to be managed and really suppress the thyroid before. So they may be on some medicines that you can't use while you're pregnant. So you'll need to be on medicines like Cytomel or other measures to kind of suppress the thyroid production within the thyroid gland. And those need to basically, for lack of a better term, burn out the thyroid before you can go on. The reason for that is just that, if those patients get pregnant, not only will they end up having a harder time keeping the pregnancy, but then it'll definitely affect the fetus as well. So that's the other reason to do that first.
Okay, that's very useful to know. Thank you. Going back to end on some questions, if that's okay, if you've got time. Someone said, how do you know if you have thyroid issues and if it's affecting fertility? Well, I presume you answered that by saying that you would do a panel screening and that's one of the ones you would test for. But how would you know if that's what's affecting your fertility?
Well, the key thing is that's working with your physician, working with your provider. That's one of the things that hopefully they'll bring up as an issue. If your thyroid hormone is actually normal, then that's not likely to be affecting the cause of fertility at all. So it's not the first measure to go through and actually say that this is a cause. It's usually one of several other things that may contribute to the issue, and one of the several things we'll need to address. The only one where it may profoundly be cause is if the hormone level is either really high or very low. Those are the ones that are going to be associated with repeated miscarriages and other issues as well. And those are going to, you'll end up having some symptoms with those. Either, again, having the heart palpitations or having, issues related to, eating or weight loss or weight gain. Those are things you'll actually have to look at.
Someone's asked, is there anything to do with Clomid and thyroid antibodies? Is there a connection there?
There are some old data that may suggest that repeated exposure and repeated stimulation with Clomid can raise those antibody levels for a short time. Again, we're talking about really low levels of antithyroid hormone. It's not going to push someone into basically a full-blown autoimmune issue. So that's not an association that's ever been diagnosed or actually been seen. Okay. So again, not a cause.
And what about a connection between, or any correlation between, thyroid and AMH levels?
Not there actually. the best way to think about it is two true and unrelated. The thyroid hormone, it basically affects the thyroid gland. AMH is a reflection of what you call the antral count. And AMH is primarily produced by the ovary and some of the glands around the eggs themselves. So it's not something that actually is made by the pituitary gland. So it may be found in the pituitary gland and it may be stimulated within the pituitary gland, but it's actually something that's actually primarily within the ovary itself. So therefore, someone's AMH should be totally independent of their thyroid function, thyroid hormone.
Okay, thank you for answering that.
Mm-hmm.
Someone has said that their daughter has congenital hypothyroidism and wonders whether she could experience fertility issues in the future.
It's possible that she could, so therefore that's something that will need to be managed. Usually if someone has congenital thyroid issues, there may be other, and it's related to some genetic issue, then that may be something where other hormone system within the pituitary gland are affected as well. So typically you'll end up having not just the thyroid gland being affected, but it may end up having, the ovary being affected, the adrenal gland being affected. It's a part of that that hypothalamic pituitary axis that's going to be functioning.
Okay. Someone has said, they've said that fertility clinics aren't worried about antibodies. Should they be? I mean, what do you think about antibodies at Laurel Fertility Care?
It depends on which type of antibodies. So again, really low levels of anti-thyroid antibodies are not really associated with reproductive loss. So therefore, it's something where if someone has recurrent miscarriages, it's part of the profile that we'll evaluate, but that's not part of the measure that we'll say is going to be a key component. If there are other measures within that recurrent miscarriage panel, such as anti-cardiolipin antibody, basically lupus anticoagulant and all the other ones, then you may say that those are associated with basically reproductive losses, and those need to be actively managed. But if the only thing you're finding is a low anti-thyroid antibody, then most times that's not going to be managed or treated at all.
Okay, because someone said, why don't clinics do a full thyroid panel and only test TSH and free T4?
The thyroid panel in someone who is actually not having recurrent miscarriages is probably going to be, it's not all labs are even capable of basically doing the T4 and all the other measures, and it's a really sensitive product to use. Even if you send them to reference labs, such as in our in the US you have Quest or LabCorp, not all of them are going to actually be able to measure them accurately. There's variation between labs, so therefore that's the other thing to be concerned about as well.
Okay, thank you. We've had loads of questions come in which are very specific to their medical diagnosis and protocol. So I would suggest that you can DM us or DM Laurel Fertility Care to set up a consult with Dr. Schmeichel, who can help you answer those questions. But I don't know whether you'll be able to answer them for individuals based on what they're taking, etc. You said how often you should get your thyroid checked, so thank you for that. Someone said, can it just suddenly happen? You sort of answered that, but is there anything else you want to cover in terms of it suddenly appearing out of nowhere when it hasn't been there before?
I wouldn't say it suddenly appears out of nowhere, but you do have basically environmental exposures that may end up having a profound effect in a region. So this is going way back and probably well below before your time, but basically if you remember the incident in Bhopal, probably about 25, 30 years ago, there was basically an incident where a lot of people got exposed. Many of those patients ended up being hypothyroid. They also had a lot of other basically functions, hypothalamic functions that were affected as well, but that was a profound effect. It's pretty unusual for individuals within the community to just spontaneously have something happen just because of that. So they may end up having propensity to it, but it's something that you can actually measure over time.
Good to know, thank you. This is a great question. Can thyroid issues impact implantation of embryos?
Hyper or hypothyroidism, if they're profound, can actually affect implantation. That's one of the reasons we want to try to basically make sure that person's in the right range before. So, that's something that's affected. The reason for that is that there may be receptors within the endometrium as well that are actually going to be affected. So another thing to kind of basically help to manage that.
Okay, brilliant. Thank you. Well, thank you everyone for your questions. I'm sorry we're just not able to go through every single individual questions, but as I said, Dr. Schmeichel would be more than happy to consult on a personal level if anyone wants to speak further and gain his expertise. Is there anything that you think would be important to end on whilst we're in Thyroid Awareness Month?
I think the biggest thing to do is to be aware of your circumstances. So I think the biggest recommendation would be the easiest thing to do is to get checked. If you know what your numbers are, then you can actually have a much more information in terms of how it's going to be infected for both men and women, only because, it does affect men as well. So that also affects sperm. So, the key thing is get tested. Knowledge is important. And, it gives you a lot more information in terms of basically being able to control, your circumstances. So that's going to be the thing I'd end on.
So if people are trying to conceive naturally, they should get it checked as well?
That's true.
Yeah. Okay.
Mm-hmm.
That's really useful information. Thank you so much. And thank you everyone for joining. It was wonderful to do my first live with you in 2022. And we've covered some great ground. So thank you everyone. And thank you, Dr. Schmeichel.
Not a problem. Here's to a great 2022.
Definitely. Bye-bye everyone.
All right.
Thanks for joining.
Bye-bye now.
Bye.
Okay.
Bye.